Wonderful. Good morning from California. We are going to share our slides and get started with session 11 of our Foundations in Critical Care webinar series. Handing over to Dr. Sammy Benjamin.
Thanks, Dr. Crawford. Good morning from California slash Chicago to everyone else in the world. I'm Dr. Benjamin, and I'm here to co-host with Dr. Walker the 11th session of our Foundation in Critical Care series. So welcome back to all you who have followed along for the previous sessions, and to those who it's the first session, welcome, and I hope you'll enjoy our presentation. This one will be on maternal hemorrhage. So I'll go ahead and introduce our panelists. Dr. Kelly Federick is an obstetric anesthesiologist at Stanford University. Dr. Jean-Claude Uwimana is an anesthesiologist in Rwanda. He's very familiar with working in district level hospitals, so his perspective will be quite important to our conversation. I think you all might already know Dr. Anna Crawford, the mastermind, who is an anesthesiologist and critical care doctor at Stanford as well. Dr. Amos Zakaria is an anesthesiologist in Tanzania. He's also experienced in both rural and academic settings. Dr. Alfredo Urdaneta is an emergency medicine and critical care trained doctor at Stanford as well. And Dr. David Stull is the division chief of anesthesia critical care at Stanford University. So, thank you to all our panelists for joining us today, and I'm looking forward to having a good conversation.
Dr. Benjamin, do you mind introducing yourself and Dr. Walker for those who
Oh,
didn't do it
oh yeah,
previous webinars? Thank you.
of course. Yes. Dr. Walker is also an emergency medicine doctor at Stanford University, and I am a previous surgical critical care fellow at Stanford and currently a trauma and critical care surgeon in the United States in Chicago. I think we can.
I'll do the next couple slides. We just want to remind everyone that this is a place of learning. So we want to be respectful of each other. We all come from different training backgrounds. We all work in different settings. So we want people to feel safe to ask questions. So if you disagree with something, please do so with kindness. We use the Q&A or question and answer function. If you have questions for these panelists, please put your question in the Q&A box and we will try to answer them as soon as possible. We want to build a community of learning. So introduce yourself in the chat box. Let us know your name, where you're from, and how you practice if you're a nurse or a physician, and what are some key points of your practice. We want to get to know you too. This session is being recorded. Your attendance is your consent to be recorded. We also will put all of our slides and the recording on the Learning Resource Center. We'll share that link in just a second. We are also being streamed live on YouTube, so your presence is a consent. I'd like to highlight that we have the closed caption. This is a great option for those for whom English is not the first language. All of our panelists will try to speak slowly and clearly, but if the closed captioning helps, you can use that, and it should be at the bottom of your Zoom screen. The Learning Resource Center is a free and open access platform that any of you can access. This series is part of the Foundations in Critical Care course. All of our lectures, all of our slides, all of the recordings are already posted on the Learning Resource Center. For this session, we will have the slides posted by the end of today, my day in California. And we will have the recording up in a couple days. So you should be able to access all of that for free. Additionally, the slides are available for download. So if you want to use them to have discussions with colleagues or to teach your trainees or students, those are also available to you. Anyone who registered for this will automatically receive a certificate of attendance. Please be patient. This does take a few business days for us to send those out. Additionally, you will receive an email and instructions on how to claim your CME, is what we call it. Some people call it CPD. So you make sure you look out for that email, and you will be able to also claim CME credits for this session and all the sessions if you attended. And with that, I'll send it over to Dr. Rebecca Walker.
Hi, thank you guys for joining us. We really have tried to keep this pretty straightforward today. So we're talking about maternal hemorrhage, a super common problem all over the world, causing a lot of morbidity and mortality. And we're going to kind of discuss that, the implementation of an emergency bundle, sort of a group of treatments that is so commonly addresses the common causes of maternal hemorrhage that it's helpful to think of them together. We'll learn to treat by the four main causes of maternal hemorrhage, and there are four T's. So if you don't take anything away from this lecture other than those four things, that's what we hope that you'll remember, the four causes and the treatments for those causes. We'll talk a bit about transfusion safety and how to transfuse safely and describe different techniques that are procedures that may need to be helpful to stop bleeding in the case that medications don't work. And then, as for a definition, maternal hemorrhage is really anything that is considered to be significant or excessive. And all of you we know are healthcare providers and nurses and physicians. So, some of this is a judgment call, and that's okay. So if you're with a woman who happens to be bleeding and it seems excessive during pregnancy, during childbirth, or the postpartum period, the most common kind of definition that we use is a blood loss of about 1 liter or more, or blood loss that seems accompanied by signs and symptoms of hypovolemia, so low blood volume, low blood pressure, within 24 hours of the birth process.
Great. Thank you, Dr. Walker. Dr. Amos, can you tell us a little bit about the epidemiology of maternal hemorrhage?
Well, thank you so much. So I think I'll really want to start with defining what is a maternal death. And this is, according to the World Health Organization, defines maternal death as a death of a woman while pregnant. But it can be within 42 days of termination of pregnancy. Now, this is irrespective of the duration of the pregnancy and the site of that pregnancy. But the cause should be related or aggravated by pregnancy or its management. And then we leave out issues like accidents and other causes of death, for example, like suicide. So this is how WHO, World Health Organization, would define the term maternal death. Next slide. Yeah. So really, how bad is the situation? So postmortem hemorrhage remains to be a leading cause of preventable maternal death worldwide. This is across the really many countries. And the majority will occur within 24 hours, often before a care is available to the patient. And when we look to the lower and the middle income countries, the numbers do not look fine. It counts to almost 99% of maternal deaths are due to the postpartum hemorrhage. So the numbers are overwhelming. But the causes of this postpartum hemorrhage have been studied worldwide in 3 modes of delays. The first mode of delay is a delay to decide to seek for care. And the second mode is reaching to a facility, okay, talking about the infrastructure. And then the third delay is when a patient is at the hospital, but you fail to receive a care which is needed. Now, in all countries, these delays have really caused problems and have worsened the conditions. And in the rural areas where the infrastructure is a problem, these delays have really caused the problems. I want to cite a few studies, for example, in Egypt, where they did a 10-year analysis of maternal deaths in a tertiary hospital, where they found really how they are arranged is vice versa. You find that over 88% of delays were due to the failure to receive care at the facility. Okay, next slide, please. Now, let's also talk about the prevalence of maternal mortality causes according to ICD maternal mortality. Now, according to a systematic review and a meta-analysis, again, this is from WHO, which is a very famous article. We find that the most prevalent cause of maternal deaths listed, in a descending order from the highest to the lowest, were the non-obstetric complications, accounting to almost 48.32%, followed by obstetric hemorrhage. So now you see obstetric hemorrhage comes to the second. But this might not be the same in all countries. For example, in my country, obstetric hemorrhage is number one, okay, accounting to almost 33.3%. And then other causes are like hypertensive disorders of pregnancy, and childbirth, puerperium, and other obstetric complications. So what is the point to note here? That obstetric hemorrhage is a very common cause of maternal death. But what is important is that it's preventable. It's something which is preventable, and we can do something about it. So if we can do something about maternal hemorrhage, we are sure that we can save the lives of many mothers who are in danger as we speak. Thank you so much.
Thank you so much, Dr. Amos. I have a question for the panelists. What factors would lead to a woman delaying her decision to seek care? Are there cultural things? Is it an economics? Like maybe she's concerned about having the money to pay for healthcare. Is it because the journey is so far away? Is it all of the above? What are some of your thoughts?
I think I'll just speak from the experience we have in Tanzania. For example, when you go to the rural areas, I think I would say it's all of the above. I would say, from economic hardships, beliefs they have, even how the laws are. Really, people think twice before you make that decision to go and to attend the, healthcare at any kind of facility. So I would say really the causes are really from different, causes. You cannot like single out one major thing which you can point out.
Yeah. Okay. Thank you so much.
Yeah, thank you so much. And we've talked about patience throughout these presentations just to kind of give us some sort of focus. But one of the things that we will talk about later in this presentation too is the risk factors that a woman may have during her known pregnancy that, as Dr. Amos mentioned, all the reasons that a particular woman may delay seeking care. There also may be opportunities for us as healthcare providers to let them know that they need to be in a certain place when they are delivering because they are maybe at a higher risk of having these complications. So here's our patient, Sophia. She's 38 years old, and she gave birth to a full-term infant, and the baby's doing well. She had no previous problems during her pregnancy, but she did have 2 term pregnancies before, and she is bleeding after her delivery. She has a fast heart rate, and she senses that her nurse is clearly noticing that this seems to be an increased amount of bleeding. And we'll do an answer in the, oh, here we go. The survey's up. So should this nurse start a fundal massage, order a blood transfusion, set up for a balloon tamponade, or apply direct pressure?
Ten more seconds. Okay, what do you think?
This group is on it. Everyone got the right answer, you know, the thing that is the first foremost thing to do. So, and we'll talk about all these other things as well as some more medications too.
Wonderful. So start a fundal massage. Great. Good job. 80% of the people got it correct. Can we hear a bit more about the pathophysiology from Dr. Jean-Claude?
Yes. So to the pathophysiology obstetric or maternal hemorrhage, to understand where it is, we have first to remember that during pregnancy there are changes that occur. Among those changes, there is also increased uterine blood flow. Normally, before pregnancy, the uterine blood flow is around 100 mils per minute. But during pregnancy, it is increased up to 700 mils per minute. Another mechanism that can contribute to a hemorrhage is the myometrium that is not that did not contract well, that cannot clamp down during atony, and also the sinusoid of placenta bed that can still remain open after delivery. As also pregnancy trauma also can contribute to maternal hemorrhage, and trauma, a pregnant woman who is having trauma, maybe genital tract lacerations. That trauma can lead to what we call little triad. The little triad it consists of coagulopathy, hypothermia, and the acidosis. That little triad will result in the exacerbation of ongoing hemorrhage, and it will be like a vicious cycle. And the many causes of maternal hemorrhage, as was mentioned a little bit at the start of this presentation, they are in four. They can be categorized in 4 T's. The first T, which is the major one because they contribute to 70 to 80% of the causes of maternal hemorrhage, is atony. The second T is the trauma. Trauma, it can be either laceration, trauma to the cervix, to the vagina, or or even to the uterus, like when there is uterine rupture. Or another T is the retained product of retained placenta product. Even clothes can be also included in the T, in that tissue. And the other T is the thrombin. We know that pregnancy is a hypercoagulable state, so troubles in coagulation, also coagulopathy, can lead to maternal hemorrhage. Next slide. So okay.
Go ahead.
So I want to ask the audience if do you have any techniques in your settings where you use to estimate blood loss? If you have some of those techniques, can you tell us which one? Just mention it in the chat box. The techniques that you use to estimate blood loss.
Yes. So how do you estimate blood loss? I will give them maybe 20 more seconds. Is that okay, Dr. Uemame?
Okay. Yeah, it's okay. Mm-hmm.
You have to say,
So
you have to say Nakibazo.
Yeah.
Okay. Let's see what they said. Do you want to read some of the answers in the chat box?
Yes. So see they are saying there are some who are saying like so counting goes yeah, pads I think they would maybe they wanted to tell us that they can also use pads. Full soaked goes 150 mils, number of soaked swabs. Yeah, I think you got some of those techniques. So basically, there are different techniques that can be used. Maybe the most common used, especially in limited resources, is the visual estimates. The visual estimates, as some of you have been saying, involves counting surgical gauze, maybe laparotomy sponges, and also drapes. And you are just counting, but also we have to see how the saturation is. If that gauze is soaked with blood, it is the quantity we estimate is not the same as when it is not saturated with blood. And also we have also to see on the surface, because sometimes blood can spill on the surface. So we have also to see to estimate the quantity which is on the surface, or sometimes also on the side of the operating table. That is the easiest one, but the most common used. But the problem with this one, it has been found that sometimes it can underestimate the quantity of blood loss. So using also suction canisters is one of the techniques that can be used. There are canisters that are graduated, and you have to see at which level the blood that is being that has been lost, at which level it is, and you have to include that blood in your estimate. Basically, suction canister, it can say that is a part of visual estimates. And also another way to estimate blood loss is weighing sponges, which is a gravimetric method. Weighing sponges, gauzes, sheet, or pads. The way someone can do it is just you weigh the sponges, gauzes, sheet, and pads before operation and at the end of the operation. Then you have to subtract, to take the weight before the weight after operation. You subtract the weight before operation. Then and also you have to take into account that sometimes gauzes can contain other fluid, maybe amniotic fluid and others. So you have to know to estimate that other amount that can be and you remove that other amount that is not blood. Then when maybe you get that weight, you have again to start estimating blood loss. Normally, 1 gram of blood, it is equivalent to 1 milliliter of 1 gram of weight. Because you have weight, is equivalent to 1 milliliter of blood. So when maybe if you have weight like 200 grams, it will be around 200 milliliters of blood loss. Then that method, you can use that method, or we can also use another method of measuring hematocrit changes. With this method of hematocrit change, there are different formulas that you can use. Of course, you have to consider the hematocrit the patient started with. Then you consider the hematocrit the patient is having now, and also you have to calculate the estimated blood volume for that patient. Then you use one of those formulas. Then it will help you to know which amount of blood that has been lost. So you can ask yourself which one among those common methods for estimating blood loss I can use. As I said, that visual estimate can sometimes underestimate blood because there is a study that was conducted, and he has found that surgeons and anesthesiologists, they tend to underestimate, especially for obstetric and orthopedic cases, and to overestimate in spinal surgery cases. So You can use the visual estimate, or you can use the suction canister, but it's better to use many methods at the same time, because it will help you to be as accurate as possible. Another way of estimating blood loss is using the shock index. The shock index is the shock index basically it doesn't estimate blood loss, but it helps you to start to know whether you can start resuscitative measures. The shock index is the ratio of the heart rate to the systolic blood pressure. Normally, the normal shock index should be around 0.7, but when it is above 0.9, you have to act immediately and start triggering blood, thinking about it, starting blood transfusion. Yeah, those are when you use, maybe if you start, you depending on where you are working. If you opt to use maybe visual estimates, and you use also the shock index, and you see that it is the visual estimate shows to you that the patient it is a moment to start blood transfusion. And you use the shock index. Those two, if they show you that you have to start transfusion, you have to consider that one, and you trigger transfusion as quick as possible.
Thank you so much, Jean-Claude.
Yes. Okay.
Let's hear a little bit more about the emergency bundle from Dr. Federer.
Sure. So if you have identified that there is a hemorrhage ongoing, which is a very critical first step in saving a mother's life, there are a couple steps that will be life-saving that come after that. And here's an example of an emergency bundle of care that outlines what the first priority should be. And in those first 15 minutes, especially, which are very, very critical, your immediate priorities are sixfold. And I will emphasize that these don't have to happen in a sequential manner, that they could happen simultaneously. And obviously, you need several hands on deck, and you need a lot of help in the room. So the first is to call for that help into the room through, whatever mechanism you have in your facility. And this is going to require a wide range of team members. You're going to want more physicians. You're going to want more nurses in the room, any technicians that can help with equipment, whatnot. People who come to the room do have to have clear roles. We know that sometimes when emergencies occur, the rooms can get a bit crowded and loud and chaotic. So making sure that people know what their role is really important. And then starting a timer to determine where you are within that 15 minutes is also important. And again, everybody does need to know their responsibility. Person managing the patient at the bedside, whether this be a midwife, a nurse, an obstetrician, another physician, should begin uterine massage immediately to stimulate uterine contraction and reduce bleeding. This, of course, happens in the setting of both a vaginal delivery and in a cesarean section as well. The first drug that we're giving in almost all of these situations of maternal hemorrhage is oxytocin. And of course, this is a drug that enhances uterine contractility. Different facilities have different protocols for administering this. Some prefer to give it intramuscular, some prefer to give it intravenously, some follow it with an infusion. Whatever your facility finds to be the most effective, efficient, and have it most quickly available is probably best for you. And then we also ask that people consider tranexamic acid. So this is an antifibrinolytic drug that really, really can be effective in reducing bleeding when it has been established and when it's given early. It's not all that effective when we try to give it in a preventative manner in the similar way that we give oxytocin. But if you do have a hemorrhage established, this is a very effective drug that you can give to try to prevent worsening of that hemorrhage. And then finally, we're going to ensure that we have a lot of IV access. So at least 2 large bore IVs. What your definition of large bore might be different. I would consider that at least 18 gauge. Anything bigger than that is even better. This is for rapid fluid resuscitation, and then potentially if you need to give blood transfusions, this is what you're going to be needing. Of course, if there's difficulty getting IVs, you might be looking at central lines or intraosseous access as well, just to ensure that you have quick access. And then, of course,
may I interrupt you for 1 second and ask you about that central line, because this is a common source of confusion often for our students and sometimes our trainees. Is a central line considered a large bore intravenous access?
Oh, I feel like that might be a trick question. Depends on the size of the central line.
Right. Yeah, absolutely, absolutely. So the typical central line, because it is so much longer, you have a greater amount of resistance. So if you put in, for example, a triple lumen central venous catheter, that amount of resistance is actually going to be too great to rapidly transfuse lots of blood and blood products. So if you were going to do a central line, it would actually need to be a large bore central line, such as a Cordis or a MAC, so like a pulmonary artery catheter introducer type of line. Through those lines, you can transfuse quickly, but a standard central line is not considered a large bore IV. You might have to do a central line, but if you do so and you're needing to do like massive transfusion or quick fluid resuscitation, then consider doing a larger catheter. So not really a trick question, but definitely a source of confusion for many people. So I just wanted to point that out. And I agree with you. I think of 18 gauges or larger. So, 18, 16, 14. Those are the large bore IVs. And I don't know if any of our panelists would disagree with that.
Yeah, that's kind of the 18 is the minimum that we have on our labor and delivery for most deliveries. Good point. Thanks for pointing that out. Definitely the bore of whatever you do centrally, peripherally is going to matter because of the resistance that you might face with the fluid that you're giving. And then the final point is to ensure that throughout all of this care in this bundle, that a thorough examination is ongoing to identify the source of bleeding and escalate care as needed. We heard about the different types of obstetric hemorrhage, the 4 T's. So determining what the cause of that hemorrhage is obviously going to determine what sort of interventions you offer and which are going to be most effective. So doing that all the while escalating care within these 15 minutes is super important. Now, the WHO, the World Health Organization, has a really helpful infographic and mnemonic that might be helpful to post in your delivery suite. The mnemonic is emotive, and I'll go through what everything stands for here. It's an evidence-based bundle, gives a structured framework to detect and treat postpartum hemorrhage early. So, when in doubt, if people are task saturated, if it's very chaotic, looking to a visual aid like this can be very, very helpful. So the E in emotive stands for early detection and trigger criteria. So we heard from Dr. Uwimana about detecting hemorrhage. This is where you might be using those calibrated drapes, other means of estimating blood loss, doing lab tests, that sort of thing. So ensuring that you have the means to detect it early and trigger a bundle such as this. M is for massage of the uterus. This should be done immediately and really should continue until you see some contraction in the uterus, or at least for a full minute. O is for those oxytocic drugs that we talked about. Again, I think the WHO on this slide offers a couple different protocols for how you might deliver this. It can be given IV, it can be given IM. As mentioned, some give it in an infusion after as well, but this should be something that's prioritized very early. Tranexamic acid, common recommendations are to give 1 gram over 10 minutes or diluted in a bag of crystalloid that you're also giving simultaneously. Along that line, giving IV fluids in addition to those drugs. You're wanting to give these for resuscitation and also ensuring that you have that extra IV access and that it's a large bore, as we just discussed. The V stands for examination and escalation. So you want to ensure that the bladder is empty. That's something that can hinder assessment of the uterine contractility, and it can actually hinder contractility itself, evacuating clots from the uterus, looking for tears or lacerations with internal examinations, and then also assessing whether the placenta has been removed completely. So this is that retained tissue part of the differential that you're looking for when it comes to hemorrhage. We're wanting to escalate immediately if bleeding doesn't stop after your first response, or if you can't identify or manage a cause. This is where we're asking for help and escalating care and means of diagnosis as well.
Thank you so much. It's amazing.
Thank you, Dr. Frederick. So to kind of expand on that, these are obviously very high stress, very intense situations. So having ways to remember how to progress thoughtfully through these scenarios is helpful. So one of the ways that you can easily remember some of the main causes is by the 4Ts. That will also help guide some of the actions. These are the main causes of postpartum hemorrhage and the primary treatments and actions that should be taken to save the mother's life. The first T is tone, or lack of tone, and the treatment would be, as discussed before, uterotonic medications and balloon tamponade, which we'll talk a little bit more about later. The second T is trauma, so traumatic lacerations that either should be addressed through just direct pressure or impacting, or if you have the skill set and the tools around, then actual direct repair. The third is retained tissues. So retained placental tissues can also be a cause of continued bleeding. And that should be removed safely, meaning that it shouldn't just be a blind sweep. That can often cause more damage to the tissues and more bleeding, but should be done, when possible, under direct visualization to remove those retained tissues. And then, of course, the last one will be coagulopathy. Just like we have the lethal triad and other types of hemorrhage, that can certainly occur in maternal hemorrhage as well. And as mentioned before, TXA should be given and has been shown to be extremely helpful in decreasing mortality in this patient population. And as always, continuous reassessment should be done throughout the care of these patients. Just because you identify one cause doesn't mean there's not others, and just because one cause has been addressed doesn't mean that other causes should not be thoughtfully approached as well.
Great. Thank you so much.
Good day, everyone. I'm going to focus now on one of the 4Ts, which is tone, and we're going to talk about why it's an important contributor to postpartum hemorrhage, as well as previously mentioned, how we can treat it through our first line and second line agents. So when we talk about tone, we mean uterine atony. And what this means is when the uterus lacks muscular tone, we have this process called uterine atony. And since the uterus is a muscular organ, this lack of muscle tone means that it's not able to continue to clamp down after contracting for delivery. Normally, the myometrium should continue to contract, squeezing the placental arteries to shut down and reduce bleeding. In atony, this process is prolonged or also hindered, and it leads to the prolonged bleeding that we see in postpartum hemorrhage. Some of the key factors for uterine atony include prolonged labor, which fatigues the uterine myometrium, multigravid pregnancies, which can stretch the uterine wall, repeated distension of the uterus from multiple pregnancies, a full bladder, which pushes against the myometrium, and medications that can sometimes be given during labor, including magnesium sulfate, terbutaline, nifedipine. Another important risk factor that we don't mention here, but I want to make sure people are aware of, is infection, especially chorioamnionitis can be a serious cause of uterine atony. Additional risk factors identified in recent systemic and cohort studies include previous postpartum hemorrhage, cesarean birth, anemia, no antenatal care, and assisted reproductive technology. So those are all factors that we need to be aware of that could predispose individuals to having uterine atony and thus having postpartum hemorrhage. Uterine atony, as previously mentioned by Dr. Ooi, is one of the most common causes of postpartum hemorrhage, accounting for approximately 70 to 80% of postpartum hemorrhage. One of the primary treatments that we talk about is massage. And you can massage the uterus by doing the fundal massage, or as you see in this diagram, doing internal massage through the vaginal canal. But another important component is drainage of the bladder. And I want to discuss this a little bit because I think that sometimes we forget about why this might be important. Bladder drainage is recommended as part of the treatment for uterine atony in the context of postpartum hemorrhage management because a distended bladder can impede uterine contraction and worsen atony. Emptying the bladder facilitates uterine involution and reduces bleeding. So that is one of the key reasons why we recommend draining the bladder and leaving a Foley catheter in place to ensure that you're able to get appropriate involution and contraction of the uterine myometrium. The next therapy that you're going to be trying is oxytocin. Oxytocin is one of the first uterine tonics that are recommended, and the World Health Organization and the Association of Women's Health, Obstetrics, and Neonatology Nursing recommends routine administration for almost all births and as a first-line agent to reduce the incidence of postpartum hemorrhage due to atony. The typical dosing, and I know there was a question early or in the chat, is 10 international units IM or via slow intravenous therapy. If there's continued postpartum hemorrhage, there are some second-line uterotonics that can be delivered. Here we mention misoprostol, but there's also other medications such as methylglobin, carboprost, and carbotocin. And it really all depends on what is available within your own region. And so the therapies of oxytocin and misoprostol are more commonly available, but it is important to know that they do have some potential side effects. So I did want to discuss some of those side effects. So with misoprostol, you can administer it both orally, sublingually, or rectally, and it is generally reserved for settings where some of the other agents are that I mentioned, the methylglobin, the carboprost, and the carbotocin are not available. It is highly associated with fever, nausea, vomiting, and diarrhea, so you need to be prepared for those potential side effects. If you have continued bleeding after you've administered both your first-line therapies, which are emptying the bladder and doing massage and then giving your uterotonics, you can then proceed on to, can you go to the next slide, Anna? Using balloon tamponade. The most commonly commercially available device is the Bakary balloon. But if you do not have the Bakary balloon available, there is another opportunity to use a Foley catheter and a condom loaded onto the catheter to use similar to the Bakary balloon. And what I want to describe is just kind of how you would assemble that. So first, you would secure a latex condom onto the Foley catheter tip and test for leaks. Then you would insert the Foley catheter that is covered with the condom into the vaginal canal. And then you would start to instill 200 to 500 mLs of saline through the catheter until resistance is felt and bleeding is slowed. Afterwards, you would then secure the Foley catheter by gently pulling traction into the internal os and then securing the Foley catheter to the thigh. You would then continue to monitor and observe for bleeding and leave in place for 6 to 24 hours while ongoing monitoring and continuing to perform the other therapies that you have, including the massage, the uterotonic agents. And then the last thing you would do is deflate and remove, deflate to ensure that there's no ongoing bleeding and remove the bleeding or remove the Foley catheter. And I wanted to stop there to allow some time for questions. Dr. Crawford?
Yes. So I would just say we'll have the learners put the questions in the Q&A or the chat box, and we'll try to get to those at the end. Just for the sake of time, I think we should just continue on with the rest of the uterine atony slides.
So if your therapies, your initial therapies have failed, your next option are surgical options. And so one of them that could be done is a uterine compression sutures, also known as the B-Lynch suture. uterine artery embolization, but this uterine artery embolization requires interventional radiology and may not always be something that is available to all the different settings that you will be practicing in. Uterine artery ligation and internal iliac ligation requires exploratory laparotomy to be able to identify those vessels, and so it's a much more aggressive. And unfortunately, one of the last therapies that is a final option and hopefully is only necessary in very rare cases is a full hysterectomy to remove the uterus and to stop the bleeding. And unfortunately, it is still sometimes required, even in different hospital settings, including in first world settings, for continued ongoing maternal hemorrhage that has not responded to all the other therapies.
Great. Thank you so much. That's a great review. Okay.
All right. Now, a quick question for the audience. So Sophia's medical team knows that her uterus might be atonic. It's a very common cause. So a quick question, what should be given to Sophia at this moment?
Sorry, I'm trying to move that.
No worries.
It's not working very well.
Well, I see a lot of answers in the chat. Looks like everyone's in agreement. Oxytocin, number 2.
All right. Great. I'm trying to move that. Hold on just a second.
Great. So we've done a very deep dive into the first T tone, and so now we're going to switch to another one of the 4 T's, which is tissue. So as you know, every time a woman goes through delivery, they also have to, after the baby is delivered, deliver the placenta. And there are times where there's retained products of the placenta in the uterus that cause ongoing bleeding. As Jean-Claude went over the differences in all of the blood flow to the uterus during pregnancy, increases the blood flow 6-fold to the uterus, and all that muscle contraction is meant to expel it. But if you have something that's structurally in there, a part of the placenta, that can cause ongoing bleeding, and the treatment for that is to remove that piece of the placenta. That is a procedure that is taught during the also course, the advanced obstetric emergency course, and you have to know how to do it, but ultrasound can help. So identifying under ultrasound where exactly the pieces of retained placenta are. The bleeding will likely continue until the parts of the placenta are removed in its entirety. So my job as an emergency physician is to really identify those patients with ultrasound guidance and to give a call to our obstetric colleagues so that we can get this patient under their care so that they can really do the definitive treatment. So that's kind of blind. You don't want to blindly try to remove the placenta, but you can be trained to do so. And so I think that's an important thing to remember as you're treating for atonia, which is the most common cause of maternal hemorrhage. If that bleeding continues, then it's important to look for this other very important cause.
I just want to point out to our learners, that's the second time that this panel of experts has said, do not try to remove retained products of conception or placenta blindly. So make sure that you have somebody who knows how to do that, that is called to help, like an obstetrician.
Yeah, absolutely. And this is kind of goes back to people that are at high risk. You hope that they are near a facility with obstetric care if you think that they are going to be at high risk for ongoing bleeding, which might require obstetric specialty care. And another T, the third T, is trauma. Vaginal delivery can certainly cause a lot of trauma to the vaginal canal. If there's ongoing bleeding, as you can imagine, the vaginal canal is very a mucosal area. So even a small arteriole in the vaginal canal can get torn, or a large laceration, of course. But even small things can happen during the vaginal wall, and it can produce a persistent arterial bleed that can be small enough to even miss on early detection, but persistent enough to cause a major problem if it does not stop. And those arterioles, importantly, or even lacerations up higher in the canal, they might not be detected with a bimanual exam, and they might not be able to be controlled unless you identify exactly where the bleeding is coming from. So trauma from outside can be a bit more obvious, like very painful tears, but under delivery there can be varicose veins in the vaginal canal, and that might be the cause of bleeding with minimal or no trauma. So those will not be managed with uterine massage or oxytocin. So if there's ongoing bleeding, it's important to rule them out by performing a speculum exam to identify where those bleedings are, where the bleeding is coming from. And then at that point, there may be the need for direct pressure or tamponade or suturing, or urgent surgical assistance, as we mentioned, from the other causes as well, for even IR or obstetric doing cautery or ligation.
This all sounds very painful. Dr. Stahl, before you get into coagulopathy, can you tell us just a little bit, what are some of the pain control options for these mothers that are going through this very traumatic and probably painful experience?
Yeah, I think we often worry about pain control because we don't want to cause more hypotension, but I think that often can interfere with our ability to get good hemostasis. And so I think it is really important to consider whether it is early use of systemic opioids, or if you have a neuraxial either catheter in place or a block in place, to utilize that to get good pain control so that we can get control of the tissue, which ultimately will stop the hemorrhage.
Yeah. I think some of the IV medications might be more available in most settings. In a lot of settings, we don't have epidural catheters, unfortunately. But if you do have that option in your setting, I think it could be incredibly helpful for these women. Thank you. I just wanted to touch on that quickly.
So we're going to pivot and talk about the fourth T, thrombin or coagulopathy. And some of this will be a good test to see how well you were listening to Dr. Uemama and Dr. Fedoruk earlier. But really, when we think about coagulopathic bleeding, vigilance is key. This is a time where it is easy to see a little bit of bleeding and to convince ourselves, oh, it's not that much, or oh, it's not that bad. But really, our index of suspicion and being able to say that, hey, any bleeding should be thoroughly investigated is critical, particularly in high-risk patients. So patients who have prolonged labor, who have preeclampsia or HELP syndrome, or who have intrauterine infection or sepsis. If you are concerned about coagulopathy, this is a time to start transfusions. This will prevent further hemodilution of the clotting factors by using crystalloid to resuscitate the patient, and will allow you potentially to get ahead of some of the downturn side effects from blood loss. We mentioned earlier that extrapolating from the woman trial using tranexamic acid, 1 gram as early as a hemorrhage is recognized is important. And a question came up in the Q&A about the timing of that. And a meta-analysis found that delaying that treatment every 15 minutes decreases its effectiveness. And after 3 hours from the beginning of the hemorrhage, there's really no benefit. So this is something to give early in your suspicion. And then, anytime we were worried about disseminated intravascular coagulopathy, we would like there to be a great treatment for that. But there really isn't, other than fixing the underlying cause of bleeding and continuing to resuscitate. And then we mentioned earlier the lethal triad, and we'll go to the next slide here. And just as a reminder, when we're thinking about coagulopathy, what is the lethal triad? You can put in the chat or you can think about it.
Oh no, I can't move this thing again. Okay. I'm going to skip the poll because it's very challenging for me.
No problem. Let's go to the next slide.
Okay.
So the lethal triad extrapolates from decades of trauma literature, which shows that when we have hypothermia and acidosis, we worsen our ability to form clot. Of course, ongoing bleeding can then further exacerbate underlying metabolic acidosis. And all of this can be compounded when we give excess crystalloid, particularly normal saline, which can worsen the non-GAP metabolic acidosis because of hyperchloremia. So then the natural question is, how do we break this lethal triad? And really, this is a multifactorial approach, which is early use of blood products, stopping the underlying cause of bleeding, and ensuring that the patient is warm, both by warming the temperature of the room, by covering the patient, and by warming fluids that we are administering.
Can I ask a couple clarifying questions? And this may put us behind in time, but I think it's really important. And I anticipate these will be questions for our learners as well. My first question is, if you don't have blood available, would you use crystalloids? And if so, how much? From all of the panelists. I don't want to put just Dr. Stahl on the spot, but anybody can answer this.
I'm curious what Dr. Walker and Dr. Urdaneta think, because I think this comes up in the triage setting quite
Emergency room.
frequently.
Yeah.
But I think for me, it is enough crystalloid to maintain the minimum level of perfusion. So it's targeting some lower MAP, some lower organ perfusion without causing more hemodilution.
Do you
But I
have a
saw that
map?
up.
Do you have a MAP number in mind?
For a healthy patient, I'm often thinking around 50, but Alfredo has unmuted
I
as
would
well.
probably go, yeah.
Yeah, I think both in the emergency department setting and in ICU, I've used crystalloid to try to get to a map that it shows adequate perfusion. We always say, we like 65 millimeters of mercury, but as Dr. Stahl mentions, really there's not a magic number. You really want to see, are they perfusing? So in the resource limited setting, you're not going to be able to necessarily get an invasive arterial monitoring. You're going to be using other clinical signs such as capillary refill to determine if they're adequately perfusing. And so I tried to target a map where I can see that they're showing signs of adequate perfusion, using lactate as a marker for hypoperfusion, capillary refill, and not necessarily targeting a specific map if I don't have blood products available.
Wonderful. Okay, next question. Would you use Ringer's lactate or sodium chloride as your resuscitative crystalloid until blood arrives?
I worry about the non-GAP metabolic acidosis that can develop from hyperchloremia. And so I tend to avoid normal saline for volume resuscitation and would use lactated Ringers.
Same. What about you, Dr. Stahl?
Yep, I agree. I think that although the number needed to harm is not super low, I think where you have access to a more balanced crystalloid, the better.
Yeah, I would choose Ringer's lactate, which is probably the most common balanced salt solution available. Okay. One more question. Would you use blood products or whole blood in your resuscitation? And is whole blood available in your setting? I'm going to go with Dr. Alfredo first, and then Dr. David.
I would use whole blood over the different component therapy, and we do have whole blood available. It is a little bit of a challenge to get, but we do have it available in certain settings. I am the medical director for our aeromedical transport via rotary wing, and so we do get whole blood, and we've been able to convince our blood bank to give us whole blood. but it is a little bit more challenging. But whole blood is, in my opinion, preferred and has all the different components that you need without having to worry about thawing of different sorry.
Great. Okay. Dr. Stahl, what's your experience?
I interestingly came from an institution that did not have whole blood to one that now does. And I'm going to defer my answer to a couple slides from now when we talk about transfusion, because I think there are some
perfect.
different ways to approach it.
Great. Okay. Let's keep going then. Thank you guys so much for letting me digress.
All right. So we've touched on some of all the main causes and the treatments for them as well, but this is a study that is important to bring up because it showed that as we mentioned before, can be obviously more than one cause of maternal bleeding. So we shouldn't get pigeonholed into thinking that just because we've identified one and that we potentially started adequately treating it, that there's not a second reason. And so this is a study from the Lancet that synthesized 327 studies as a meta-analysis, identified that multiple causes for bleeding were around 8% of cases. So this supports the use of treatment bundles and the management of postpartum hemorrhage. After uteroneectomy, the most common causes were genital tract trauma, as mentioned before, retained placenta, abnormal placentation, and coagulopathy. So important to always keep those in mind. And as we mentioned before, reevaluation of the patient continuously throughout resuscitation is key.
Wonderful.
This is a really nice kind of flow chart published by the New England Journal of Medicine. It's pretty comprehensive in terms of a lot of the things that we described. One of the things I wanted to point out is, at the top it says screening for all women with risk factors, right? So ideally, before our patients come for their deliveries, we would have already have identified who is at high risk for peripartum hemorrhage, and then they would be optimized. And then once they're brought into the labor delivery section, then we would be able to kind of prepare and mobilize whatever resources might be necessary based on their risk. After the development of postpartum hemorrhage, this chart does a nice job of very comprehensively kind of breaking down what your immediate responses should be based on what your estimated blood loss. So I won't go through all of them because it's pretty comprehensive, but you can see there, if you're thinking of at least a liter of blood loss, then you're already thinking ahead, right? You're notifying anesthesia, you're delivering placenta retained tissues, all the things that we already discussed, uterine massage, IV fluids, oxytocin, et cetera. As that progresses, then you're going to start adding your TXA, you're monitoring for your persistent coagulopathies, and then you're administering more blood products as if the patient becomes more unstable. And as that progresses into your more and more hemorrhage and all those other options have been exhausted and are potentially not effective, then we're activating our massive transfusion. And then you're going to, depending on what your institutional resources are, you're going to mobilize some of those other options. Whether that might be if interventional radiology is available for uterine artery embolization, and of course, surgical interventions if should already have been mobilized at this point to be on standby if necessary. So again, pretty exhaustive, but this is a nice kind of like breakdown of what the different options would be based on what your estimated blood loss would be, as well as highlighting the need for a screening of women for risk factors.
Thank you so much. I think these infographics and algorithms are really helpful. And Dr. Fedoruk mentioned earlier, it might be helpful to have these on the wall or posted somewhere in your obstetric suites to help with those decision-making questions that come up during these situations. So these will be on the slides uploaded on the LRC, so you guys can pull down these algorithms and infographics as well later.
Yeah, thank you. So this, one thing that we talked about even just a minute ago about what are these high risk situations and how do you decide what your next move is? And even the thought process of putting ourselves in a location where someone is bleeding out and there's no blood available, it's a pretty scary thought, right? And so ideally, we're trying to develop referral networks so that these patients that are at high risk are already at an institution that might have blood products before delivery. And so these high risk patients include multiple births in the past, or someone who's taking anticoagulant medications, someone who has had previous complications or comorbidities, someone who has infection, like Alfredo had mentioned. And so really, in one of those questions about what do you do when there's no blood, one of my biggest moves would be to try and get on the phone and get that patient in another place to go to. So, have referral networks in place so that you can identify what the next step is, because that lactated ringer might not work. When the patient's losing blood, they probably need blood. So if you're trying to stop it, but also trying to get them to the location where they need to be. These alternative medications that Alfredo talked about in detail, carbetocin, ergometerine, and misoprostol, if oxytocin is not available, or in addition to if it doesn't seem to be working.
Perfect. Thank you so much.
Yeah. So I think another thing to consider is what if a pregnant woman is on anticoagulant? So what do you do? I would say, well, pregnant women will be on anticoagulant due to many reasons. Might be due to their comorbidities, or maybe they are obese. And low molecular weight heparin and unfractionated heparin are preferred and in pregnancy because, number one, they are not teratogenic. Their safety is good, and also their predictability and unfractionated heparin. It's has a short half-life, so they are normally preferred during pregnancy. Now, I would say many of the reasons as to why we stop anticoagulant. In many literatures, really the reason is because of the worry of neuroaxial hematoma. But really, many cases have shown that there is no need to stop anticoagulant if the patient, for example, is going for normal vaginal delivery. So the patient will be on anticoagulant, number one, for prophylaxis or for therapeutic. And it's advised, if there is a high risk of bleeding, for example, to stop prophylactic anticoagulant not less than 12 hours. And if the patient is on a therapeutic dose, then you have to hold at least 24 hours before any kind of procedure or anything that you want to do. Now, here comes a question. If a patient then develop hemorrhage, you have to reverse with protamine. But I'm worried because I'm really talking about the experience from our setup. How many centers, for example, in my country would have a protamine available? Perhaps it's just available in a few centers. And perhaps I would say the drug which maybe you'll depend on will be tranexamic acid. So I think my take is there are several reasons that a woman may need to be on anticoagulant during pregnancy, and it is recommended to stop this anticoagulant for delivery, but the cases are out there that even without stopping anticoagulant, there was no any significant blood loss which maybe could be announced as an emergency. Thank you so much.
May I ask you, Dr. Amos and Dr. Jean-Claude, is it accurate to say that protamine might be available in your tertiary hospitals, for example, in Dar es Salaam or Kigali, but perhaps not available in the district hospitals? Is that accurate?
Yeah, it is
for me,
not.
It's very accurate. Yeah.
Okay. Jean-Claude?
Yeah, it's accurate. You cannot find it in district hospitals, but tertiary it is possible to get it. But mainly King Faisal in the Yeah, Uganda Military Hospital. Yeah.
Murakoze Tani.
Yeah.
Dr. Fedoruk, what is your experience when you've been working, for example, in the Balkan states? Do you think that protamine is readily available?
I haven't seen it personally, so
Okay.
I can't comment on that.
Okay, perfect. Perfect. Thank you so much, everyone. We'll keep going now. Dr. Stahl.
So, we were talking a little bit earlier about transfusion. And when I think about transfusion in a resuscitation, it's really two big goals. The first is to maintain a balanced transfusion, and we'll talk a little more about what that means. And then to have large access and a way to administer the blood rapidly. And we talked a little bit about earlier about the benefits of a short, fat peripheral IV versus a long, thin central venous catheter.
Did you agree with my opinion on that one?
I do. I think that we often our focus on central access detracts actually from our ability to get peripheral IV access. And often our pregnant patients have good peripheral venous access if we look for it. In terms of the resuscitation and the balanced transfusion, it's important for us to have a ratio of blood products that restores hemoglobin and our oxygen delivery capabilities, but also doesn't dilute out coagulation factors. And so, extrapolating from military and trauma data, this has evolved to a balanced transfusion of a ratio of 1 to 1 to 1 of red cells to FFP to platelets. But that is not a kind of must-have ratio. And that's where some of the data on whole blood has come into play, because that essentially gives you that same ratio back. But we also know that fibrinogen levels are much higher in pregnant patients than the average patient population. And so occasionally adding cryoprecipitate, or in resource-rich countries where there is a synthetic fibrinogen, might be beneficial. We also know that pregnant patients often have conditions which impact platelet function. And so sometimes giving additional platelets can be helpful. During this resuscitation, it's really important to think about, again, maintaining warmth, managing acidosis, maintaining calcium, as all of our citrated blood products will bind with calcium. And then where you have access to monitor labs, being able to get those can help you further tailor your resuscitation in terms of what products you're going to give over time. And then being thoughtful about monitoring for overtransfusion, and when the bleeding stops, to know when to de-escalate your transfusions so that you don't unnecessarily give blood products that can lead to volume overload, or transfusion reactions.
Wonderful. Thank you so much. That's really, really helpful. I keep pressing us for time, saying we're going over, but then I keep interrupting. But I think these points are really important. And I know that Dr. Alfredo has military experience, and I've done quite a bit of research in this as well. But whole blood is often used not only in obstetrics but also in military situations, because it's most available. And I think historically we used to always use whole blood, and then we started to divide the blood components so that we could actually transfuse more patients with one donated unit of blood. For example, somebody with thalassemia. But when we're doing massive transfusion, what we're actually trying to do is recreate whole blood by giving the 1-to-1-to-1 transfusion. So I think it's really important to consider whole blood in these patients if it's available in your setting. Where I did my training for anesthesia, we did a very large number of obstetric cases, and we did use whole blood in those situations as well. Thank you.
Okay, now we've heard about most of these, but just looking beyond a lot of the pharmacologic management, when that's been exhausted, and especially when it's not working, we should probably be looking pretty early to surgical interventions, especially if the hemorrhage is severe. So when medical management fails, now some of these are appropriate for all types of hemorrhage. Some of them are only appropriate for certain types. So a balloon tamponade, which we've heard a lot about, and there's been a lot of discussion in the chat about how to do this on your own or with a Bakri balloon. This is effective in uterine atony. Compression sutures are something that need to be done surgically. So this is going to be in the setting of an open abdomen, whether you've done a cesarean section or if you have a laparotomy for another reason. B-Lynch is something that they're commonly called. These allow for compression of the uterus so that you don't have an open cavity that the bleeding is freely going into. Both of these preserve fertility, so they are attractive first step options, especially, like I said, for atony. For kind of all comers causes of hemorrhage, we can also look at arterial ligation. So this could be the uterine artery, the utero-ovarian ligation, or internal iliac. Something that's complicated with the pregnant vascularity and blood flow to the uterus is that a lot of collaterals develop. So for both arterial ligation and the interventional radiology embolization, which I'll talk about next, sometimes they're fraught because there's a lot of collateral blood flow. So even though you're cutting off blood supply with one means, it might not be all that effective. Regardless, you do need a skilled operator to do this. This can also preserve fertility if you do maintain some of that collateral blood flow, but once again, a lot of surgical expertise is required to appropriately identify the arteries, obviously. Interventional radiology, typically with like a gel embolization, is an excellent option when it's available. I realize that this is something that might not be accessible worldwide. It's particularly useful for ongoing bleeding from specific vessels that can be identified. So the downfall of the arterial ligation I mentioned is that you might not be able to identify exactly where the bleeding has come from, but typically with interventional radiology, they can particularly target which vessel is contributing. Does require immediate access to interventional radiology. Even at our big center at Stanford, sometimes this is difficult for us to access for our obstetric patients because it's quite far away. So you need to have a stable patient that you can transport as well if you are required to do that. And then finally, hysterectomy remains our last resort. This will definitively stop uterine bleeding. It sadly also ends fertility and carries significant surgical risks. Doing a hysterectomy on somebody who's not pregnant is a very different surgical experience than doing it on somebody who has recently been pregnant and has a very vascular uterus. Even though it's a very critical, high-stakes decision, it shouldn't be delayed if other measures have failed and when the mother's life is at risk because it is life-saving. Overall, the key is knowing when to escalate, not getting fixated on things like pharmacologic therapy or some of the lower invasive interventions that we can see at the top of the screen. Maternal survival is our top priority, so you do have to move through these pretty quickly if you have a life on the line.
Thank you so much. It's very useful.
So now I'm going to talk about shock management after you have appropriately volume resuscitated a patient. Fortunately, the management of postpartum hemorrhage shock after appropriate volume resuscitation is no different than how you would treat sepsis. Norepinephrine is still the first line agent as a vasopressor for administration of or to maintain your mean arterial pressure, aiming for ideally a mean arterial pressure greater than 65, acknowledging that in resource limited settings, you may not be able to have invasive arterial monitoring, and you'll be titrating to either clinical parameters such as how is the tissue perfusion when you check capillary refill, or if you're able to check whole blood lactates, checking to see if the lactate is improving. You can still use vasopressin and phenylephrine as directed by your ICU specialist. The reason you want to worry about phenylephrine is while it is a very potent vasopressor, it can cause bradycardia and which can lead to decreased cardiac output. And in the settings of postpartum hemorrhage, that decreased cardiac output could actually lead to further hypoperfusion and endangering the other organs that you're trying to make sure are getting adequately perfused. Vasopressin can be used as well, but if you're doing it in someone who has actually not delivered, you do need to monitor the fetus, and then make sure that you are monitoring after delivery of the fetus if vasopressin is used. You can deliver vasopressors peripherally. Ideally, you want to use a large bore IV above the level of the wrist to try to avoid infiltration of the vasopressor into the tissues that can lead to serious necrosis. But it is very reasonable to use peripherally administered vasopressors and not having to have a central venous access to deliver that. The other thing that we want to talk about is, while vasopressors are important, is that you need to also correct acidosis and hypothermia as part of the ensuring that you're adequately perfusing your tissues and end organ function. Again, this acidosis and hypothermia is going to lead to the worsening of that lethal triad, which is going to lead to further hemorrhage.
All excellent points. Thank you so much. I think also for those who have access to an ultrasound, which you might be using to place your peripheral IV or your central venous access, or to actually look at the uterus, you can also just if you have the right probe, you can also look at the heart when you have that ultrasound machine out. Some of these pressors are not available in all settings. So we talk about norepinephrine and vasopressin in particular. So if epinephrine is all you have, then that's all you have, and you have to make good decisions through which you can save the mother's life. So we recognize that these agents are not available in all settings. Thank you, Dr. Alfredo.
Thanks. And I'll just kind of lastly sort of remind everyone that we're talking about something that causes such a huge morbidity and mortality for women, and it is heavily preventable. If the risk factors are identified, the person is in the right place, and they can get the right treatment. And so that's kind of why so much of global health, in our lifetime has been focused on maternal hemorrhage and maternal child health. And these are just some systems-based things to consider. This is that QR code, and I can put a link in the chat based on the Emergency Obstetric and Newborn Care. It's MONC. And this is a tool that's used by ministries of health, the WHO, for operational planning, and measures signal indicators for both the quality and the availability of different levels of functions, and where basically this is sort of trying to stitch together where are the gaps in care for a particular place. The tool is free, and I'll put it in the chat where you can email to get that tool in French or in English. And that kind of helps, there's many of us that are working on system strengthening in our own institution and more broadly. So just to kind of something to be aware of. So thanks.
That sounds like a good quality improvement project for somebody working maybe in a district hospital or somewhere where they could improve the resources. I would love to just thank all of our amazing panelists from lots of different practice settings. Certainly we have several from a high-income country with very high resources at Stanford University, but special thanks to those who have worked in low and middle income countries and who have worked in resource-constrained settings. So really, really grateful for those perspectives, in particular, Dr. Amos and Dr. Jean-Claude. You can scan this code again for the Learning Resource Center. It was also in the beginning, but all of the slides and everything will be uploaded to the Learning Resource Center by the end of today. And as soon as the recording is processed, we'll also upload that as well. We do have, let's see, 7 minutes. So I would like to go through the Q&A and see if we can answer a couple of those questions while we still have just another minute. Can the presentation be shared? We talked about the Learning Resource Center. Oh, you guys answered a lot of questions. So open questions. David, hello, David, says midwives are often the first responders and perform uterine massage to stimulate contractions. They give the uterotonics such as oxytocin and misoprostol. They do manual removal of retained placenta when trained, and the use of non-pneumatic anti-shock garments. That's a great point that we didn't mention. And uterine balloon tamponade in severe cases, referral coordination for surgical intervention when necessary. Some of the challenges that are faced by midwives. I said midlife because I think I'm having my midlife crisis, maybe. Midwives, despite their vital role, they do face several barriers: inadequate training and refresher courses on emergency obstetric care. I know, Dr. Federock, you work a lot in teaching OB anesthesia in places like that. And I think Dr. Uemana and Dr. Amos have also been involved with that. Delayed referrals. We talked about the three things that delay care. So it's deciding to access care, delays in getting care. And then when you do arrive in a tertiary center or a more highly resourced center, you may not be recognized early enough as having life-threatening hemorrhage. Emotional stress and burnout. Absolutely. That's a great point as well. Thank you, David, for those comments. We really appreciate your perspective. David Mira is a colleague who works in lots of different low and middle income countries, and we know each other through the Essential Emergency and Critical Care Programs Network. Are other African countries making use of the eMotive program? I would say yes. I don't know, Jean-Claude, do you guys use eMotive in your obstetric suites? It's the WHO infographic that Dr. Federock went over.
Have they?
Can you unmute, please? Sorry. There you go.
Yeah, so the emotive, we use it, but maybe the problem, because it is a district hospital, there are some that that I recommend that we don't use, but we use most for each item. We have something to use, but as I say, there are some that we don't use because it is some that are missing in a district hospital.
Okay.
Yeah.
When doing
Okay.
pressors peripherally, is the dilution the same as when using central access? I think yes. Even in our septic patients, we talk about how we can use pressors peripherally temporarily, typically less than 24 hours. When you are using vasopressors in a peripheral IV, it's really important to recognize that if that IV is not well within the vessel, that those vasopressors can infiltrate the subcutaneous tissues and cause lots of ischemia and necrosis. So for that reason, to have a peripheral IV, you want it to be a very good, well-functioning peripheral IV. Dr. Alfredo mentioned that it should be above the wrist. I actually love to go into the antecubital location for this. I don't know if Dr. Alfredo, Dr. Stahl, you have any other experiences from your critical care that talks about vasopressors running peripherally. What are your thoughts?
Yeah, it's for us, our standard is to start with peripheral vasopressors. As we mentioned, we try to get it at least a 20 at the level of the wrist. Antecubital is better, but you want to make sure that when you are testing it, that you test the IV to make sure that there's no evidence of infiltration. And then we do use a lower concentration of the vasopressors and administer that. And then that gives us time to decide, are they going to be a rapid responder to the vasopressors and to resolution of the shock? And they don't need a central line, which has its own inherent risks, or we're going to need to transition to a central line. But that way we're at least administering something to maintain mean arterial pressure greater than 65, ensuring end organ perfusion, and not rushing to try to place a central line.
Dr. Stahl.
Yeah, I would just add that I think monitoring the IV site is really critical. And this is where we are very fortunate with our nurses who are watching them constantly to make sure that there isn't an infiltration. And if there is, they catch it early, because in our experience, if you catch it early, there often is not significant tissue injury. But if you infuse a large amount of vasopressor into the subcutaneous tissue, you can see pretty catastrophic outcomes.
Thank you so much. We have one more comment in the Q&A, not really a question, I don't think, but it says in smaller centers, should we be adjusting those thresholds, say triggering transexamic earlier, because retrieval delays will actually make 1,500 cc's or milliliters look more like 3,000 by the time the patient is at a tertiary care center. And I think all of us would probably say yes, as soon as the patient is recognized as having maternal hemorrhage, that tranexamic acid and those other treatment options should begin, whether they're in a tertiary center or not. Does anybody else have anything to add to that?
Yeah, I think I agree with that. And also, along with this idea about a peripheral line having pressors, if you cannot monitor that line and you are going to send someone on a long transport, then that might be a reason to consider putting a central line before that transport so that that can be monitored.
Perfect. That's a great point. With that, we will conclude. It's 8:30. Our time is up. Again, thank you so much to all of the panelists. We really appreciate you volunteering your time to teach and train others. And thank you to all of our wonderful learners. I love to see you every single time, and I'm so glad you're here. We have one more session in this series, which will happen next month in October. It will be a frequently asked questions session, where we take all of your questions from when you've registered or attended before, and we'll have a group of expert panelists again from all over the world to help answer some of your frequently asked questions. And with that, thank you so much. Don't forget to go to the Learning Resource Center to download the slides. And thank you for all of these wonderful emojis and reactions. It makes me so happy. Thank you. Bye.
Bye.
Marcos y Charme, merci. Gracias.
Thank you.
Asante sana.
Rebecca, bye.
That's a new one for me.
Thank you very much.
Thank you.
Ana Maria, bye.
In Shona, we say
Thank you so much for the wonderful presentation.
See you next time.
Malta Basa.